Perfect. Thank you, Victoria. I greatly appreciate it, Dr. Ron Hartz. And just to tell everybody, thank you. I appreciate the opportunity to be able to talk to you today about navigating reimbursement. I know that for me personally, I've worked with EMS, traditional EMS revenue cycle management now for 16 years, and mobile integrated health has definitely been a topic that I've been very passionate about since maybe the 2015 timeframe. And just to see the evolution and the different ways that people are using mobile integrated health, to me it's just fascinating to see how something has evolved and how it's become such a key part of the industry that we're part of. I'm not going to do a pitch on what I do professionally as far as working with our partner, but I definitely want to tell you guys, as you have questions as we go through this slide deck, I'd be more than happy to answer questions, stuff specifically about mobile integrated health reimbursement. So if you have questions, please feel free to put them in the chat. And if I can't get to them, I'll have all my contact information and everything at the end. So we'll have a ability to kind of go through it, or you can reach out to me directly. So be more than happy to talk about that. So with that being said, we'll go ahead and hop right into the presentation. All right, so to start with, obviously, we're all here for a reason, right? Times are changing. Things are evolving in the industry that we're in. And, I think it's really, like I said, it's really neat to watch this evolution happen and watch things change within the industry. It reminds me of in the beginning of my career working with EMS services. We went through a kind of a similar transition when we talk about basic fundamentals of the way that we operate our service. And just kind of a quick show of hands so we can get everybody interactive here. If you could raise your hand if you remember charting your patient care reports on a paper PCR. Good question. Who remembers that, right? So most people here, right? Looks like most people have experienced going through and filling out a paper report. So I don't know if you guys remember the challenges and all the adversity that we had to overcome in the beginning to transition from the paper PCR that everybody was using out there to move towards the electronic PCR components. I never will forget trying to work with key stakeholders here and really show the value, the everything from just being able to show trends, security, mitigating risk. I mean, there's tons of different factors there, right? And it's crazy to me to see how many of those things really are still applicable, and we're still working to evolve that. But I guess you guys see, obviously times change, right? And with going back to the EPCR example, now we have this national data set. Everything is recognized, it's credentialed. It's become the standard of the way that we report our patient care reports up day in, day out. And there were, like I said, there were a ton of challenges. I feel like there's still some challenges that we have to deal with working with that. But at the same time, that evolution has happened. We've been innovative and we've been able to create a new system. Now, I'm not sure if you guys have Googled mobile integrated health lately, but if you go on to Google or Yahoo, you start just Googling mobile integrated health, it's crazy to see how many different examples come up of different ways different people are using mobile integrated health, and all of the different systems, different things that are in place that people are really trying to take advantage of to get the right care to the right people at the right time, right? So times are definitely changing, times are evolving, right? But one of the biggest challenges I think we all deal with when we look at mobile integrated health is how do we create a system that's sustainable, right? Sustainability is the key here, right? And when we look at sustainability, it really is the key driver of innovation, right? Because we have to find new ways to be efficient and effective, and creating that means there to be able to continue providing that service better, to be able to make those changes. So reimbursement really is a critical part of that sustainability. So today we're going to talk about 3 different mechanisms there for reimbursement, specifically around mobile integrated health, right? So the first one is going to be our traditional reimbursement that we're seeing out there. And we're going to talk about some examples of things that have previously happened, things that are kind of happening now, look at some grant funding opportunities that we're seeing out there in the market, and then look at our non-traditional mechanisms of payments. And that's going to be really an interactive session, I hope, so I can kind of open up the dialogue and hear, what different folks are doing, and I'll give you guys a little bit of insight into what I've seen out there. But at the end of the day, the goal is really just to get the conversation going. So let's go ahead and move on. So when we look at different mechanisms of payment, I think that it's always important, first and foremost, to look at the revenue cycle as a whole, right? Just the fundamentals of what we look at to create a sustainable revenue cycle. So there's a couple pieces, and this isn't too long and drawn out. I'll try and get through this pretty quickly, but I think that this is definitely something that's important for us to take into consideration. So the first piece there is that we have to identify all stakeholders that would be impacted by the services we're providing. So when we look at the stakeholders with mobile integrated health, obviously the patients first and foremost, right? The family members that we're going to be impacting, the providers or suppliers that are going to be given the service, our payers, our regulators, and the facilities we're going to be working with that are going to be seeing or caring for the patients. Second of all, credentialing. And that's one thing that I know that this association is passionate about and is really a key for any method of payment, because you have to have as we kind of say sometimes, a higher power there. This credentialing. One of my favorite little memes that I've seen used in this is a little joke that was talking about how Moses was only a lifeguard for one day, right? As he split the pool as the person was diving in. And really having that credentialing up front keeps us from jumping into something that we don't know what's going to happen. We don't know what the result is going to be, because we have a mechanism to say, this is what it is. This is how we define it. This is what you have to do to be able to provide it. So it's definitely important there that we identify or have good credentialing up front to understand exactly what that is. And that could be organizational license with state, whether that's state EMS jurisdictions, from an individual clinician license, that can be accreditation, health plan or payer expectations. So there's a lot of stuff that really kind of falls into that credentialing bucket. But again, it's something that's very important. The next part of it is really understanding the service that we're going to be providing, right? And then be able to come up with a coding schema to be able to associate that service with a specific charge. So again, that's going to be more geared towards the patient or the care, the specific intervention that we're going to be providing. And it has to be patient type calibrated, but we have to understand exactly, again, services, procedures, and how we would bill for those in the back end. The second part of that is understanding the modifiers, right? So one of the key pieces we look at with mobile integrated health is, are you going out to deal with low acuity emergency or 911 type patients? Are we dealing with post acute care discharges, or we following up? So there's obviously multiple models, different models that we see out there. So having modifiers out there to determine location, circumstances, context of care, any type of algorithms or things that we can do to show what we're doing is definitely something that we need to, that we want to take account of. The next part of that is condition and diagnosis coding. So that's really getting into validation of their initial impressions, what kind of services, again, applicable services, the scope of the service that we're providing, the value of the application, the service that we're providing. So there's a couple different things that fall in there, but again, understanding the condition codes. The next part there is just understanding the basics of claim submission. So, what demographic information will be submitted with the claim. What clinical documentation would be needed to support that claim as it goes through the payment process? Are there, special processes there that we need to identify within each payment plan or different fee schedule schema that we see? So we see different types, obviously different types of fee schedules that are, payment mechanisms that are out there, whether that's traditional fee for services, value-based payment systems, cost savings, sharing, I can spit it out there, or capitation agreements. So there's many types of payment schemas that are out there. So identifying exactly what we're working for here. And then understanding what's going to be the responsibility of the patient. Is it covered or is it a non-covered service? Are there going to be copays? Are there deductibles? What's the incentive for the patient to be able to participate in the program? Make sure that that's clearly defined. Oh, I skipped one real quick. Let me go back. And the last one there is special considerations. Right. So again, are there any types of additional information or oversight that needs to happen for the revenue cycle to take place, whether that's oversight from a federal level to improve the service, whether that's at the state level to approve protocols that we put in place, and just the basic economics of the system. Is it going to be feasible, and are we going to be able to sustain? So when I have folks talk to me about mobile integrated health and they say, hey, is it possible to get paid? Right? Just kind of taking this back to square one. If I start providing the service, is it possible to get paid? And let's see, I see a couple things popping up in the chat here. I don't think that those are, I think those are questions. Yeah, we'll get back to those, right? So when I talk to folks about, is it possible for mobile integrated health to get paid? The answer is yes. Actually, we have just had a mechanism there for reimbursement from Medicare. And we'll talk about Medicare real quick, because if you guys work in traditional EMS services, you see that Medicare is kind of the governing body there that controls a lot of the payers that we're going to work with. But through COVID-19, through the PHE, we were actually given a mechanism there to be able to bill in lieu of transporting the patient onto the facility. Now, there was a lot of caveats specifically to that rule, and I don't think it was exactly what it was intended to be initially, but there was a ton of work that was put in to creating this mechanism of reimbursement. So I think that it's important there for us to recognize, one, it is there, or it's existed, but two, how do we create this, or how do we bring this into play, hopefully for something that's more long-term, right? So let's talk about this mechanism of payment real quick, a little bit more in depth. This was a waiver that was created specifically for treatment in place. With the waiver was the 9832 waiver. It was more specific for 911 or equivalent type calls. Again, it was treatment in lieu of transport, and it required a couple different things specifically to happen for this to be a reimbursable charge. First of all, you had to have a protocol in place that dictated that you could provide that level of care. That's one of the things that was extremely important, because that can be verbal, it could be a written protocol, but again, there's certain things that were in place. Second of all, medical necessity and things like that still applied to this type of reimbursement. So it's important just to see that it existed. Now, unfortunately, this waiver has just expired, right? So again, I want to make sure I put that out there. This is something just this past month with the PHE, unfortunately, has expired, but it's something that we need to focus in on, because long-term, again, that mechanism there, it exists to be able to get payment for treatment in lieu of transport. Now, as we look at reimbursement as it currently sits today, and I use some examples here again in the coding text of that in lieu of transport, but whenever we look at treatment in lieu of transport, we're actually able to bill out our traditional BLS and ALS claims, and we were reimbursed those rates. So there was a modifier specifically we talked about using on the back end the CR modifier. And again, that was during the PHE emergency, but there were some very interesting things that came out of this, right? Because again, there's a lot of work, a lot of services lobbied pretty heavily to be able to get this put in place. But I read a report that was saying between March 1st and I think it was the end of September in 21, there was just over 10,000 patients that were actually billed or beneficiaries of billed on behalf to Medicare for this service. And it was, around 3.5 million, I think was the number of the payment that was paid out. So there wasn't, and I'm sure you guys hearing those numbers, it's not a lot of money, right? And there was a lot of I feel like a lot of misunderstanding about what this was and really how it worked. But again, when you look at mobile integrated health at its core, going to the patient's home, treating them in lieu of transporting them is that mechanism there that we're looking at. Now, what we found interesting is we build multiple payers. So other than Medicare, just for these codes. So we had services that had mobile integrated health components that they put in. But when you look at all payers, not just Medicare, roughly 50% of the payers were paying these charges at the full amount. And I say full amount, but we had roughly 98% of adjusted charges being paid. So again, you're talking about a significant amount of reimbursement here coming in. You saw a lot of services that were doing the monoclonal antibody treatment that were using these codes, but there's several different ways that folks were using these codes to be able to get reimbursed for providing mobile integrated health. Now, one thing that I think is important here to point out, when you look at other insurance payers other than Medicare, right, there is a traditional code there that we would use whenever we bill, which is the A0998 code. And we're seeing a ton of different insurance pay this code, pay for these charges at this point. So there is a mechanism that's there to bill for treatment in place. If you're a traditional ambulance service provider that is looking at creating a mobile integrated health component. One thing that's, and I guess I'll just ask this question to the group, and I see I'm getting kind of close here on time, so I'm going to speed it up. I'm not going to go through my questions, but one thing that's important to understand, first of all, at a state level, is your state Medicaid currently reimbursing you for treatment in place. That's always a really good start. And we've seen a lot of state associations have a lot of lobbying to be able to get those rates covered at the state level. Those typically start to impact your state HMOs and CMOs to make sure we're getting paid for that AO998 claim. And also, it's important to have partners in the industry, not necessarily billing service providers, but folks that have a good understanding of what's happening with the revenue cycle management, to make sure that your codes and your modifiers you're using are the right ones for that type of call. That's really one of the biggest challenges we see with this, and I'll go back, is the way that the codes are used in combination. For instance, there's some, I think it's Blue Cross Blue Shield, that uses a SS modifier, or I'm sorry, SS location, which would be scene to scene, right? And a lot of people don't understand, depending on what state you're in, what payer you're sending the claim to, how you would want to put those modifiers together to be able to get reimbursed for the service you're providing there. Another thing that we're seeing quite a bit is grant funding. We're seeing all different types of initiatives pop up all over the place as far as grant funding. I'm not going to go, again, I know I'm getting really close to my time, so I'm not going to go too deep into this because that's not specific to traditional reimbursement models. And I'll answer any questions or anything that you guys may have on the back end about this. But one of the non-traditional payments that we're seeing quite a bit right now, first of all, the concierge medical services component has really got a lot of people's attention. We're seeing a lot of folks partner with different, whether it's primary practitioners, health departments. So there's a couple of things that you need to understand about that. You have to have an NPI set up specifically through the provider for them to be able to bill for the services you're providing, right? So that's typically more capitated agreement that you would have back with the provider. And there is legislation that's been introduced, the 7573, to make the telehealth component, which is typically the mechanism that's used to get a lot of these services paid, more of a long-term, put it into law, essentially. So it's something important to take in consideration there. Definitely seeing a lot of community partnerships because there's a lot of untapped funding, whether that's federal funding for your local healthcare, like health department, stuff like that, to be able to give better access to care. And then the last two on here, we're seeing a lot of conversations come up right now, which is the capitated provider agreements and the risk reduction agreements with your insurers. And that's really where we're moving, right? That's the next step in the progression of reimbursement for mobile integrated health. And the key there really is data, right? So we have to have enough data to be able to explain the value proposition, really define the scope of what we're doing, show the scalability of how we're going to be able to sustain and apply this to different folks that are out there that we could potentially care for, and then really clearly define our metrics of success and how we justify our service there. But you got to have data. That is something that we see time and time again. So folks know the benefit of the service, but they don't have the data to be able to back it. So with that being said, questions?
There's one in the chat, Adam. There's a question from John.
Okay, so yeah, does the service have the ability to apply for ET3? So currently, there was an ET3 enrollment period that happened initially. I think we're kind of all familiar with that. There was a certain number of services that were accepted into the ET3 pilot program. Unfortunately, we have not seen, and I will tell you, I'm not aware of another round of folks being able to get into that ET3 pilot program. But John, I'd be more than happy to follow up with you. I can do some additional research on my side and just let you know I haven't checked here in the past couple of weeks. So, but as far as I'm aware of, there's not an additional enrollment period for folks to get in.
Hey, Adam. And so just a quick clarification on my question. Does the service have to be an ET3 approved provider to be able to bill that code, or can a traditional service bill that code?
That's a great question. So as far as Medicare is concerned, right, no, Medicare would not reimburse for the AO 998 code. That would be geared more towards your private payers and now we do see some Medicaid. So again, that's at the state level. We see a lot of states out there that are now reimbursing for the treat in place, and a lot of the Medicare HMOs we're starting to see reimbursed, but traditional Medicare would not typically reimburse for the AO 998.
Adam, I've got a question related to advocacy. You know, us being an organization, of course, advocating for mobile integrated healthcare and community paramedicine as a whole. What exists, or is there anything that exists at your level or within your industry of either building services or ambulance billing, you know, an association of sorts that's advocating for positive changes like this, or to allow this?
Yeah, so, and just to make, and I apologize, I think I got the majority of your question. That was a great question. I kind of heard some pieces of it there, so I just want to make sure I clarify. So as far as what we're seeing from RCM companies looking at how we can push this forward, how we can help services be able to participate and bring in reimbursement. Is that kind of what you're looking for there?
Sure, or even, you know, is there an equivalent association, you know, amongst the billing services that is also advocating for, you know, increased scope of billing ability?
Absolutely. Absolutely. Yeah. So that's a great question. And one of the things that we look at, and I'll give you a prime example. In Pennsylvania, we have a payer up there specifically that created a plan, and it's UPMC, that covered the treatment in place for mobile integrated health components. So they worked with some of the services to really define, you know, what patients would fall, and they actually created their own component of MIH. But we have, depending on where those services are in the market, We definitely have the connections and influences and payers to be able to say, hey, look, we represent this percentage of the services out here that are providing this information. We can take that data, and it's much easier for us to extrapolate across a bigger picture to say, hey, these are the results we're seeing. This is the number of patients that would fall into this category. So we are definitely big for advocating on behalf of our clients, and really not just our clients, I mean, the entire industry, to be able to try to show that data. And really what it comes down to is having partnerships like this to be able to talk to you guys about it, make sure everybody's aware of it, so we can take that information, we can put it together and help those services present that information to the payers to make sure we're able to get them into contracts and get them paid for these services. Great question. So I know I've went past my time here. I will put my slide up real quick, just in case anybody wants to grab my contact information. Like I said, I would be more than happy to talk to anybody one-on-one specifically about, you know, our experience, my experience with revenue cycle management for mobile integrated health in different ways or different things that we can help to get you reimbursed for the services you're providing. But again, I greatly appreciate everyone's time and attention and the ability to talk to you about this.